everyone. Thank you for today's virtual education program with Cancer Support Community Los Angeles. I'm Larissa Montalvo, and I welcome you to this week's webinar titled Cancer Screening Recommendations. Today, we welcome Dr. Kelly Yap, medical oncologist and assistant clinical professor at the Department of Medical Oncology and Therapeutics Research at City of Hope. Dr. Yap will provide a general overview of cancer screening and recommendations based on national guidelines, and will include a long Q&A session at the end where you're encouraged to ask questions. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. If you'd like to learn more about our services or watch our past webinars, please visit our website at www.cancersupportla.org. Without further ado, I'd like to welcome today's speaker. Dr. Kelly Yap is visiting us from City of Hope. She received her medical degree from Queen's University of Belfast and completed her internal medicine residency at York Hospital in York, Pennsylvania, where she was chosen as chief resident. She went on to complete a fellowship in hematology and oncology at Los Angeles County and USC Medical Center. And prior to joining City of Hope, Dr. Yap was an assistant professor at Keck School of Medicine, USC. She is a board certified in medical oncology, hematology, and internal medicine. Welcome, Dr. Yap.
Hi, good afternoon. Thank you for having me.
Here, the floor is all yours.
Thank you, Larissa. So I'm going to share my screen that has a PowerPoint presentation. There we go. And please let me know if you guys are not able to see the presentation. So we're just going to jump right in. All right, there we go. This is the agenda for the next 30 minutes or so. We're going to talk briefly about cancer prevention, and then we'll jump right into the most common type of cancer screening programs. And then at the end of the presentation, we'll have a Q&A session. So we can't really talk about cancer without talking about cancer prevention. After all, I believe that prevention is better than cure for sure. And it's just really, common sense, the importance of maintaining a healthy weight, because obesity has been associated with multiple types of cancers, including most commonly breast cancer, colon cancer. Eating a healthy diet with lots of fruits and vegetables, with limiting the processed meat and red meat can also decrease the risk of cancers in general. Being physically active, meaning exercise, it doesn't have to be strenuous exercise, even, simple exercises such as walking 5 days a week for about 30 minutes a day, has been shown to help to decrease the risk of cancer and recurrence of cancer. Most of the evidence is really in breast cancer as well as colon cancer. Now, I'm sure, many people know about avoiding tobacco because of the risk of lung cancer. But we should also know that tobacco has been associated with other types of cancer like stomach cancer, pancreas cancer, bladder cancer, cervical cancer. So avoiding tobacco really is very important. Alcohol consumption, I don't think we have to eliminate it completely, but certainly limiting it. There is, we used to think that, just like tobacco, we used to think that it was associated with lung cancer and alcohol associated with liver cancer. Excessive alcohol consumption actually do lead to increased risk of stomach cancer, head and neck cancer, esophageal cancer, and believe it or not, breast cancer as well. Avoiding excessive sun exposure, as we all know, helps to prevent skin cancer. And last but not least, protecting against sexually transmitted diseases, and that includes the HPV vaccinations. Preventing, the HPV infection really does help to decrease the risk of head and neck cancers as well as cervical cancer. All right, now let's jump right straight into cancer screening. So what is cancer screening? The goal of cancer screening is to try to find or diagnose the cancer in a state before, in an early state before it's too late. meaning when it's still a curable disease. In order to have a successful screening program, we need to have a reliable and yet safe test. It will only really work if it is a very common cancer, because we don't want to be putting thousands of people through a test only to diagnose one or two cases. And most of the cancer screening programs in this country is applicable to the general population, with the exception of lung cancer screening that started a few years back, that is directed at a high-risk group, mainly people who are current smokers or ex-smokers, and we'll talk more about that. And even though the national guideline recommends cancer screening at certain age, at certain frequency, I do believe that cancer screening, the decision for proceeding with the test, should be a shared decision making between patients and their physicians, because not every patient is the same. So I would like to share with you, this is the estimates from the American Cancer Society for 2021. The top bar, it's separated to male on the left and female on the right. The top half of the picture shows the estimated new cases of cancer. As you can see, in men, prostate, lung, and colorectal are the three most common cancers. And in the bottom half, you could see that the three most common causes of death from cancer are also prostate, lung, and colorectal. And if you look on the right side of the screen, the three most common cancers in women is breast, lung, colorectal. And the three most common cause of death from cancer are also breast, lung, and colorectal. And hence, there are screening programs for these cancers. So I'll start, in the alphabetical order. We'll start with breast cancer. Depending on which guideline you look at, the USPSTF, which is the United States Preventive Task Force, recommendation is to start at the age of 50. However, the American Cancer Society and the American Breast Society recommends to start at 40. It really depends on how aggressive one wants to be. The standard screening test for breast cancer is screening mammogram. And there are certain women who will benefit from additional technology or imaging, depending on their risk factors. So say, for example, if a woman has dense breast tissue, then they would benefit from tomosynthesis or the addition of an ultrasound. If a woman has the BRCA mutation that significantly increases their risk of breast cancer, or if based on their family history, they are estimated to have a lifetime risk of greater than 20%, or if they have a history of radiation to their chest that increases their risk of breast cancer, these women should consider breast MRI in addition to mammogram for breast cancer screening. And the screening test should be done every 1 to 2 years, and there is always a question, when should one stop? In general, the general consensus is one can consider stopping the screening when one do not think that they will act on the result, or if the result is not going to have an impact on the person's life expectancy. So one way to look at it is stopping at age 75, or when the life expectancy is less than 10 years. And this is a slide on what to expect during a screening mammogram. When you arrive at the breast center, normally what they would do is have you fill out a pre-test questionnaire where you will answer some questions about your menstrual history, your pregnancy history, if any, your family history, your personal history of breast cancer or other related cancers. And then you'll be taken into the room where the mammogram is done, and they will take 2 pictures of the mammogram as shown in the middle panel and the right panel. And this is just what a mammogram will look like. And on the leftmost panel, you will see that it is a breast that is mostly fat, and the most right is a very dense breast. If you look at the most left picture, the little whitish, grayish lines, those are the breast tissue, and abnormalities normally shows up as white dots are known as calcifications, or white rounded areas that probably represents masses. And you can tell that as the breast density increases, it gets harder to find that abnormality. And that's why a standard screening mammogram may not be adequate to diagnose breast cancer in patients with dense breasts. And this patient would benefit from the addition of tomosynthesis, which is taking a few more pictures, or the addition of ultrasound. And we're last year has been quite a year with COVID, and now thankfully we have the COVID-19 vaccine. And the American Breast Imaging Society has noted that since the vaccination, there is quite a significant proportion of women that has enlarged lymph nodes, axillary lymph nodes in the armpit on their mammogram. And that frequently will lead to the suspicion of an underlying breast cancer. But in fact, it is related to the COVID-19 vaccination. So they have recommended that if a woman is due for their screening mammogram, they should try to have it done before their vaccination, or to delay their screening until 4 weeks after their final dose of the vaccination to avoid this. However, if the woman has symptoms or concerns that, concerns about breast cancer, then they should not delay the mammogram. Now let's switch gears a little and talk about colorectal cancer. So colorectal cancer, it's, as I've shown in the previous picture, that is one of the 3 most common cancers in both men and women. The recommendation is to start screening at age 50 for the average risk person. Sooner if there is a high risk, for example, if there's a family history of colorectal cancer, or if the patient has underlying diseases such as Crohn's disease or ulcerative colitis that increases the risk of colorectal cancer. There are multiple different tests, as you can tell. The simplest and least invasive test is stool testing. It is not very specific in that and not very sensitive in that it doesn't pick up every colon cancer. It has to be done every year. Flexible sigmoidoscopy and colonoscopy are quite similar in that it involves a camera that is inserted into the large bowel to take a look inside. The benefit of that is that if there is any abnormalities, like if there is a polyp, the gastroenterologist will be able to remove it there and then and take a sample and test to see if there's any cancer. The difference, and both of them do require bowel prep, which is the part that most patients say is very, very difficult. But it has to be done only every 5 to 10 years instead of every year. And the difference between flexible sigmoidoscopy and colonoscopy is that sigmoidoscopy, so let me just take you through this picture here. So this is your anus here, and this is the distal part of your colon, and it goes all the way here, and then it connects to your small bowel. And flexible sigmoidoscopy, it starts here and ends right around there. So as you can tell, it only looks at a part of the colon, not the entirety of the colon. So colonoscopy is still considered the gold standard. Now you may ask, what about CT colonography? CT colonography does look at the whole colon. It is not it's a pretty good test. It does still require that bowel prep where you have to drink that strong laxatives and clear out your bowel. It's recommended to be done every 5 years. The downside to that is if they see something that is abnormal, you will still need to go through a colonoscopy to have, to find out if it is cancer or not. So just like breast cancer, when do we stop? In general, we say to stop at age 75 or when the life expectancy less than 10 years. All right, let's move on to cervical cancer. This is The only screening test, cancer screening test that is recommended to start at a very young age of 21. The screening test involves a pap smear. It is done every 3 years. But if a woman is over the age of 30 and has not had any abnormal tests in the past, this can be decreased to every 5 years if the pap smear is done with what we call HPV co-testing. Oh, sorry, that's a spelling error there. And when to stop? This is felt to be safe to stop at an earlier age, at the age of 65, if there is no risk factors, such as the woman had always had a normal pap smear, the woman is not a smoker, there is no history of HPV infection. Both of those are risk factors for cervical cancer, and also if the patient has no new sexual partner, because that will increase the risk of having HPV infection. And then lung cancer. So for many years, many studies have been done to find out if there is a way we could diagnose lung cancer at an earlier stage and hoping to cure more patients with lung cancer. Previously, X-rays was studied, and chest X-rays was studied, and it hasn't been shown to be helpful. There is a test now called low-dose CT chest. There has been a couple of very large studies involving thousands of patients that show that it does help to detect lung cancer early and help to improve the survival of these patients that were diagnosed. The USPSTF, which is the United States Preventive Service Task Force, have recently updated their recommendation just this month to start screening at the age of 50. And to screen patients who are deemed to be high risk, and high risk is defined as having 20 PEC years of smoking history or more. And these patients are either current smoker or if they have quit within the last 15 years. And you may ask, what does PEC year means? PEC year means, so let's say if a person smokes about 20 cigarettes a day, that is one pack of cigarette. If they have smoked for 1 year, that is one PEC year. If they smoke one pack a day for 20 years, that is 20 PEC years. So with this screening test, the low-dose CT chest is recommended to be done every year, and USPSTF has recommended to consider stopping at the age of 80. And last but not least, I believe this is the last one, prostate cancer. Now, this is the very controversial one because it's certainly doing prostate cancer screening with a PSA blood test every 1 to 2 years certainly can help to detect prostate cancer at an earlier stage. But numerous studies have not shown that it does actually help to improve survival or decrease the risk of dying from prostate cancer, because many of these prostate cancers are early stage low risk prostate cancer that the patient will likely die with the cancer rather than from the cancer, and hence it's now recommended for patients to have a discussion with their doctors before they decide to proceed with prostate cancer screening. If the patient do decide to proceed with it, it's recommended to start at age 50 with a PSA blood test every 1 to 2 years. There are certain patients that, just like breast cancer, there are certain patients that has higher risk, such as BRCA mutation, family history, or African American ethnicity. For those patients, if they do decide to proceed with prostate cancer screening, and they should start at age 40. And again, when to stop is arbitrary. The USPSTF recommend to stop at age 40 or when the life expectancy is less than 10 years. So this were the guidelines that I refer to, and I've mentioned a number of times now the USPSTF, the NCCN guideline, which is the National Guideline for Cancer Treatment and Screening, and the American Cancer Society. Those are very good resources if you're interested in learning more about cancer screening. And now we're ready for questions. All right, that is a question about I presume is the lady whose mother had breast cancer but did not test positive for BRCA gene. Now, that really depends on the rest of the family history. If there is a strong family history of breast cancer at a young age, then you should consider starting screening mammograms before the age of 40. Otherwise, I will recommend to start your screening mammogram at the age of 40 once a year. Question about mammograms. So it's from Virginia and Fawcett. She says she's been getting negative mammograms every year, and now she's approaching 75 years old. Happy birthday. And do I need an exam this year? I would say if you're otherwise in good health and you anticipate yourself to live for many more years, then you should continue to get your mammogram. And from Nancy, is PSA test only a blood test? Yes, it is a blood test. And from Elizabeth, if nodules have been found on lung cancer screening, how many times do you get checked before the checking stops? Sister, okay. So I'm sorry about your sister. So for lung nodules, there is a guideline as to how to evaluate the lung nodules, and if one is found, the radiologist will make recommendations depending on the size and the feature of the lung nodules, how suspicious it looked, and they will recommend another CT in 6 months and 12 months, depending on how suspicious it is. And then if they remain stable after a while, the checking do decrease in frequency and will likely eventually stop. So there are a couple of questions about HPV. I'll try to answer that. And one question was, are late doses of HPV vaccine still effective? I am not sure of the answer to that. And I apologize. I would have to defer that to your primary care doctor. I believe right now, HPV vaccines are only recommended up to the mid-20s. And the second question is there a test for screening if one has HPV infection in the DNA or the blood? I don't believe we do that routinely. That is mostly just done on cervical, on pap smears, along with the pap smears. And there is a question about getting CT scans of the chest, abdomen, and pelvis every 3 to 6 months to follow up on a history of ovarian and lung cancer. For the first 2 to 3 years, yes, that is generally recommended, and that frequency can be decreased if there is no evidence of disease. Certainly, there's always the concern about the exposure to radiation, but especially depending on the stage of the ovarian and lung cancer, these two are, generally aggressive cancers that needs to be monitored closely so that treatment can be initiated if there's any evidence of disease recurrence. All right, let's see, what other questions do we have? So, all right, the next question is, how often to have a colonoscopy if the first one is without any polyps and otherwise clear? That would be every 10 years. And for dense breast tissue, why don't we automatically do the additional test to the mammogram? Isn't it safer to check routinely with a tomosynthesis or an ultrasound? So that is a very good question. I do believe that women with dense breast tissue should have tomosynthesis or ultrasound. I think that is a question more for the policy makers, which hopefully will change as we learn more about the increased risk of dense breast tissue and breast cancer. And the next question is, I was a smoker for 16 years, but have not smoked in over 30 years. I have no symptoms. Should I get a lung cancer screening? So according to the current guidelines, no, you do not meet the eligibility criteria or the recommendation because you quit smoking 30 years ago. Former smoke. The next question is former smoker, 20 years, one pack a day. That will be 20 pack years. Haven't smoked in over 23 years. So yes, again, if you haven't smoked in the last 15 years, then the current recommendation is not to do any screening. And chest X-ray really hasn't been shown to help. So if you are really considering, if you're really concerned and would like to do testing, I think it's worth speaking to your doctor about considering the low dose CT chest. But again, the current guideline doesn't recommend screening in your situation. So could any other lung illnesses lead to lung cancer? Yes. COPD certainly has been associated with lung cancer, but again, COPD, the most frequent cause of COPD is also smoking. So I think those are interrelated. There are other risk factors for lung cancer, like exposures to certain chemicals. Yeah. All right. Let's see. For someone who had uterine cancer and went through treatment, what do you think about how long to keep getting CT scans for every 3 months, and at what point should it go to every 6 months? This is after a year and 8 months, concerned by radiation dose of. All right, so depending on the stage of the uterine cancer, the NCCN guideline do have a very good guidance about how frequent to do the CT scans after the definitive treatment for the first couple of years, and then for up to 5 years. Generally, is about every 3 to 6 months for the first couple of years. I'm sorry, I do not know that off the top of my head. But generally is every 3 to 6 months for the first couple of years, and then maybe every 6 months for 3 more years, and then after the 5th year, generally no further routine CT scan. How often to repeat colonoscopy if twice had precancerous polyps in same or similar location in colon within 3 years? Well, again, I think that there is guidelines on it. A gastroenterologist will probably be more familiar with the guideline. I'm thinking that it will likely be at least every 3 to 5 years. All right, okay. What is the recommended age to stop annual mammogram? Well, the recommended age is 75, but I wouldn't say that there is a hard recommendation in that, these days, a 75-year-old can still have many more years to live, and if they are in good health, and if God forbid a cancer is found, if they're in such good health that they will be able to follow through with the treatment and be cured of the cancer, then I think that it's still worth doing it. Okay, so the question is, can you repeat the differences between tomosynthesis and MRI and ultrasound? So all these three are different tests. Tomosynthesis is like a special type of mammogram where they take more pictures. It's X-rays. They take more pictures of the breast, and they use a program, a computer program to build pictures out of it, so they could look to see if there's any abnormalities. Ultrasound does not involve radiation. It picks up different things than mammogram. Mammogram will pick things up, will pick up calcifications that may indicate cancer. Ultrasound are better at picking up lumps. Mammogram does that too. So they help the radiologist to evaluate an abnormality more, so they have a better idea of whether it is cancer or not. Now, MRI is generally not recommended for most women. Only a very select population of women that is at very high risk of breast cancer is recommended to have MRI of the breast, and that is because MRI is so sensitive. It has a high chance of picking up abnormalities that turn out not to be cancer, and as a result, in order to find out whether it's cancer or not, the women would have, go through multiple other tests and, biopsies and so on and so forth, and creates a lot of unnecessary anxiety. So unless there is a very high risk for breast cancer to start with, breast MRI is generally not recommended. All right, that's a question about a spot in the liver that the doctors do not think is cancer and they're monitoring it. It's very difficult to answer this question without knowing the details because a spot in the liver can be due to so many reasons. But in general, the general rule of thumb, which is normally works out quite well, is if this has been stable for a while, it's likely not cancer. And over time, the frequency can certainly decrease. But unfortunately, I won't be able to give you any details without knowing what exactly it was. And so this last one, why is pancreatic cancer so hard to diagnose? Yes, it is very hard to diagnose because it's an organ deep in the abdomen. The abdomen is such a big cavity. Normally, it doesn't cause any symptoms until it's very advanced. And unfortunately, as of today, we still do not have a good test, a good screening test. I know there's a lot of research about blood tests and breath tests and things like that. So hopefully in the future, we would have a good screening test. But right now, there isn't any test that has been shown to be helpful. And yeah, it's one of those cancers that is very difficult to find. All right, everyone. Thank you so much for your attention and thank you for joining us today.
Thank you so much, Dr. Yap. It was such a pleasure to have you.
Not at all.